My name is Dr. Maryl Johnson. I'm a professor of medicine at the University of Wisconsin in Madison, Wisconsin. And tomorrow I'll be presenting a talk at the International Academy of Cardiology 2015 Annual Scientific Sessions 20th World Congress on Heart Disease held in Vancouver concerning Beyond the Guidelines, New Treatment Options for Heart Failure in 2015. This is really an exciting time to be a heart failure cardiologist, and I think particularly since I submitted the abstract to present at this meeting, the two drugs that I'll be discussing at the talk have already been approved by the Food and Drug Administration in the United States. In addition, one of the drugs, ivabradine, was I first heard about at one of the previous World Congress on Heart Disease sessions as Professor Jeff Borer has been talking about this drug for some time. So I'll start with talking about ivabradine, and this drug was actually promoted as being beneficial in heart failure because of the fact that we know rapid heartbeat is a predictor of mortality in patients with heart failure reduced EF. And in this study what they did is they looked at ivabradine, which is a direct blocker of the rate of sinus node conduction, blocking a current called the funny current in the sinus node that actually leads to potential decrease in heart rate over time. And indeed in the study, they randomized patients that were primarily functional class 2 and 3 with resting heart rates greater than 70 to ivabradine or to placebo, and found that there was a benefit in terms of outcomes, primarily in terms of heart failure hospitalizations. So the one limitation of the study was that the patients were not on optimized doses of beta blockers. Only about 20% of the patients were on guideline recommended doses of beta blockers, but indeed 56% of the patients were on greater than 50% of the dose. So I think one of the residual questions really is, in patients that are not able to be optimized on beta blockers, I think this is a good drug. My personal preference would be if I could still optimize beta blockers to their recommended doses that I would do that. The second drug has a different mechanism of action, and it's really combining two of the mechanisms we know that are present in patients with heart failure. Heart failure patients with reduced ejection fraction have stimulation of the renin-angiotensin-aldosterone system, and this has been the basis for using angiotensin-converting enzyme inhibitors as well as angiotensin receptor blockers, and in a later era, aldosterone blockers for treatments of patients with heart failure. We also know, however, that the natriuretic peptide system is stimulated in patients with heart failure, and indeed the natriuretic peptides have felt to have beneficial effects in heart failure, vasodilatation and an actual preventing of sodium retention and causing diuresis. And what the drug that looked at in this trial, called the Paradigm trial, did was it combined a neprilysin inhibitor that blocks the breakdown of natriuretic peptides with an angiotensin receptor blocker, valsartan, and looked at that drug in patients, in this case, primarily with functional class 2 heart failure on optimized medical therapy. And the findings were quite phenomenal, and that is that patients that were given the LCZ drug actually had not only a decrease in hospitalization and cardiovascular mortality, which was the primary endpoint, but also a decrease in overall mortality. So this really is probably going to be a paradigm shift for the treatment of heart failure. In this particular study, the LCZ was given in patients that already had been on an ACE inhibitor, enalapril, in most cases. And so whether we should actually use this drug to start in patients that have newly diagnosed heart failure that haven't been treated yet remains uncertain. But I think these two drugs really do provide us additional options to use for patients with heart failure reduced ejection fraction that are already on ACE inhibitors or angiotensin receptor blockers and beta blockers, and have residual tachycardia, that is heart rates greater than 70 in the case of ivabradine, or that patients that just have potential additional benefit from additional blockade of the neprilysin as well in heart failure, and certainly will change our treatment of these patients going forward. Their exact clinical role in the treatment of heart failure will be gained with additional clinical experience.